A week ago, she requested a same-day appointment for evaluation of an itchy rash on her chest due to a cancellation. She was never seen later that she was Due to a cancellation, she was seen later that day for evaluation. Physical exam at that time showed dry skin, and the patient was provided with treatment recommendation. Today, the patient does not have an appointment and arrives after the office has closed. She tells the receptionist that she needs to be evaluated for her itchy skin and says, "I came straight from work. I would have been here a lot earlier, but traffic was horrible." The receptionist tells the patient that there are no appointments available because the office is closed, but offers a visit now with the nurse to discuss her concerns. The patient declines, stating that she must be examined by a physician now. Which of the following is the most appropriate next step?
Okay. Despite being informed of regular office hours and being offered a suitable alternative nurse's visit, the physician continues to make unreasonable demands. Several red flags indicate that this patient has issues with boundary crossing, coming to the office for an unscheduled appointment and arriving at after office hours, demanding immediate attention for non-emergent issue, refusing appropriate alternative nurse visit. In this situation, physician should non-judgmentally and clearly communicate exceptions and boundaries with the treatment relationship. The best approach the best approach is being direct and consistent because allowing exceptions, yielding to unreasonable demands, and paying special attention to the patient will likely reinforce boundary crossing behavior. Therefore, in this scenario, the physician should directly but politely inform the patient that she can be seen during normal office hours with regular scheduled appointment. Okay.
Okay. Next. 54 man comes to office for follow-up of back pain. He has been a friend of the physician since college and a patient for the past 20 years. The patient back pain started 2 months ago after he lifted heavy boxes while moving to a new home. Despite taking naproxen acetaminophen and muscle relaxant, the pain has continued to worsen. The patient has no numbness or weakness in the lower extremities um, and no loss of bowel or bladder control. He has no other medical condition and does not use tobacco or drugs. The physician discusses the concern that there may be potentially serious causes of the patient back pain and recommends lab evaluation and imaging studies. However, the patient declines any testing and requests prescription for hydrocodone for the next month. Which of the following is the most appropriate response to this patient request?
Okay. This patient has this patient has had worsening back pain for 2 months despite conservative therapy prompting evolution for potentially serious causes multiple myeloma. However, a this patient who is a friend of the physician declines, who is a friend of a physician, decline diagnostic evaluation and request opioid therapy. Opioid therapy is generally not recommended for musculoskeletal back pain, especially less than 1 month, subacute for less than 3 months. Phases due to evidence of harm and lack of benefit. In contrast, it is appropriate for back pain caused by malignancy, bone metastasis, or severe trauma, vertebral compression fracture, even in acute phase. Although a competent informed consent has the right to decline the treatment, physician is not obliged to provide inappropriate intervention at the patient's request. This patient has the right to decline further evaluation, but the physician is not obliged to prescribe a prolonged course of opioid therapy for subacute back pain without definitive evidence of malignancy or fracture, because these violates standards of care and can potentially harm the patient. Okay.
Mm, can you continue?
So yeah. Oh, sorry. Having a patient who is also a friend necessitates establish professional boundaries so that standards of care and patient safety are not compromised by the external concern like damaged friendship. The physician should clearly communicate what treatments are and are not appropriate to set conditions under the therapeutic relationship can continue. If the patient is unwilling to abide by the appropriate recommendation, a discussion regarding transfer of care to other physician may be necessary.
Next. Administration at a tertiary care
So
hospital
can
are
you cut short this concept?
um usually like here, like in the US, what we're taught that like you cannot take care, like a family member cannot be your patient.
Yes.
Yeah, like if you're a PCP, like a primary care doctor, you cannot have one of your patient cannot be your mom or your brother or whatever. That's what is best. Now, if it's an emergency situation, then yeah, I mean you don't have it, and they don't have access to another doctor. Then I guess yeah, you have to take care of them. That's what we're taught here. But here on the question is saying that okay, but of course that's not true. Of course, I've did a bunch of rotations where like doctors are, you know, the patients are their friends from high school and stuff like that. Of course, that's not true. But normally it shouldn't be like that, you know. But here they're basically saying that if you're going to have the patient as your friend or whatever, um,
If he
as your friend,
like if somebody is not your like somebody is your friend but you are not your his primary care physician, is it allowed to give him medication or give him test? Like,
okay, no, no,
you
uh-huh,
got my point.
no, you,
Like, I am your friend but
mm-hmm.
you are not my primary care physician. I am my primary care physician is other person. So as I am in pain, I am calling you to ask for medication and for tests. So can you give me?
Usually no, because at first I'm not your primary care physician, and then I'm your friend. So no, usually no on the exam. On the exam. Now in real life, okay,
No,
but
no,
in the exam,
stay up. Stay to the exam, don't
yeah,
go the
in
real
real life,
life.
no. In real life, no. Mostly, if you already have a primary care physician, no, I should tell you to go to your primary care physician.
Like
Now, if
in US, primary care physician based on state to state, isn't it? Isn't it?
what do you mean? What do you mean?
Like you are in Texas, so your primary care physician should be in the Texas, not like other state.
Usually, now I've seen people that have, I live in Texas, so I have a primary care here, but then I moved temporary to New York, and then my primary care, I still want to have the one in Texas because I just moved to New York for a short period of time, so and I like my one in Texas, so I keep it. And I've seen people that have two, like I keep my one in Texas and I have the one in New York. But usually, it's where you live that you're supposed to have the primary care physician.
Okay.
Yeah,
Yes, I got my point.
yeah. So yeah, it's the same. Basically, if you're gonna have your friend as your patient, you have to set boundaries. Like you cannot treat him differently because he's your friend. You yeah,
Yes.
yeah. That's what you cannot be saying. Administrators at the tertiary care hospital are evaluating approaches to reduce in hospital patient mortality rates outside the ICU. Reducing patient mortality rates outside the ICU. Okay. An analysis of recent patient deaths due to cardiac arrest reveals potentially preventable contributing factors, including delays in recognizing or responding efficiently to deterioration in patient clinical status. Which of the following interventions is recommended to improve outcomes for patients at risk for cardiac arrest in this hospital? Mm, delays in recognizing routine and assessment of burnout at the hospital model. The estimated interprofessional team to regularly monitor patient health concerning payment. Okay. Developing another system that bridges the unit charge nurse each time patient develops an emergency. Hiring an additional hospital staff and increasing the number of beds in the hospital. Using the length of shift worked by physicians and nurses.
Okay. Busy hos busy hospitals often experience delay in recognizing and responding to acute deterioration in patients' clinical status. Rapid response team RRTs can provide early intervention in case of clinical decline, and their use is associated with improved patient outcome, reduced incidence of cardiac arrest, and associated mortality. Are characterized by RRT are characterized by the following: multidisciplinary team. RRTs typically include practitioner from typically include practitioners from multiple health professions, include nurses, physicians, and respiratory therapists. Patient assessment. RRTs support primary care teams by regularly monitoring patients who are at risk of clinical decline. RRTs can assess and immediately treat patients when signs of clinical deterioration appear and preventing serious sequelae. Activation criteria. RRTs are typically activated based on early clinical warning sign manifested by the patient sustained tachypnea, arrhythmia, and uncontrolled pain.
Can you
Okay.
read C? C
Automated,
as
yes, automated Automated alert system can notify providers of deterioration in patients' clinical status. However, to be effective, an alert system should involve parameters that are specific for signs of high-risk clinical deterioration. In contrast, excessive notifications, that is, excess time for a patient develops for an abnormal vital sign and cause desensitization to alerts and leading to missing warning signals and significant events. Alarm fatigue. Okay.
Okay, next. 35 men comes to office in late October to follow up on asthma. He has lost time the mild intermittent asthma treated with albuterol inhaler as needed. Over the last 6 months, the patient has had more frequent symptoms. However, he started an inhaled steroid 4 weeks ago and has had no further asthma symptoms since then. Okay. Medical history is notable for type 2 diabetes status with insulin. Vital signs are cardiopulmonary exam are normal. The influenza vaccine is recommended, but the patient declined, stating, I got the flu shot last year and it got me sick. Which of the following is the most appropriate response to this patient?
Okay. Even though the vaccine reduces the chance of getting influenza, you can still get infection from flu from other flu-like virus. Okay. To allow a patient to make an optimal informed decision regarding a recommended intervention, the clinician should respectfully provide patient education, including balanced assessment of the intervention and a realistic presentation of likely benefit, risk, and limitation. Giving an accurate and thorough explanation to the patient can reinforce patient and autonomy and improve patient decision making. This patient with asthma and type 1 diabetes mellitus is at particularly high risk for influenza and related complication and should be strongly encouraged to receive influenza vaccination. However, he has experienced previous apparent vaccine failure, which has discouraged him from accepting future vaccination. In this case, this patient's past illness could have been due to different flu-like infection, which would not represent true vaccine failure. In addition, there may be difference between the strains in the vaccine and those in circulation. Even if the patient acquired influenza, even if the patient acquired influenza despite vaccination in a prior flu season, he is still likely to benefit from seasonal influenza vaccination because it reduces both the risk of the infection and the severity of the illness. Okay.
73-year-old woman comes to the ED due to shortness of breath and productive cough for the past 2 weeks. The patient lives independently and is active in her retirement community. She was seen by her PCP last year and has no medical condition. The patient has history of smoking for 20 years, temperature high, lung auscultation reveal right side the crackles, checks X-ray reveal right lower lobe, consolidation and solitary round lesion in the left upper lung field, which was not seen in previous X-rays. The patient is admitted and treated for community-acquired pneumonia, um, becomes medically stable and is ready to be discharged home with oral antibiotics. The physician records the pulmonary lesion finding on the discharge summary, places outpatient radiology referral for chest CT scan, and informs the patient that she will be contacted regarding her radiology appointment after discharge. Several months later, the patient is readmitted to the hospital with dyspnea and weight loss. Report showed that she was called about the scheduled appointment for the CT scan but did not attend, so the test was not completed. Repeat imaging reveals enlargement of the pulmonary nodule and biopsy confirms lung cancer. Which of the following intervention by hospital providers is most appropriate for reducing future occurrences of similar errors? Mm, hmm,
Kind of weird.
hmm,
Fewer than fewer than 20% of inpatients with incidentally detected lung nodule undergo recommended post-discharge follow-up CT scan of the management based on malignancy risk leading to preventable adverse outcome, including delayed cancer diagnosis. A common cause is lost to follow up. A common cause is lost to follow up after transfers of care, hospital discharge as seen in this patient, because inpatient care focuses on acute medical condition, and patient may not recognize the importance of assessing unrelated findings, incidental lung or adrenal nodule after the discharge, especially symptoms resolve. Timely less than 4 weeks primary care follow-up promotes completion of pending study, imaging, lab study, and health management, new medication diagnosis. During the discharge process, patients should receive high quality provider communication and counseling explaining the importance of follow-up, as this increases likelihood of attending primary care visits and completing follow-up of recommendation. High quality communication includes the following: face-to-face disclosure, allowing response to non-verbal cues, patient-centered interaction, tailored the patient's current motivation, goals, or ability, and interactive approaches for verifying patient understanding, inviting questions, encouraging feedback that summarizes the patient's understanding of the conversation. So these short summaries can be routed to the primary care providers for review when patients attend to their post-hospitalization appointment. Okay.
Okay. Next. Administrators at a large national health insurance network are developing a performance-based financial incentive system that is designed to measure and improve quality of medical care provided by physicians. The network implements a quality reporting system that asks physicians to submit monthly clinical data on various preventive metrics, such as the percentage of physicians eligible, patients who have completed cancer screening or who are currently taking evidence based medication therapy for chronic conditions such as heart disease. Bonus incentive payments are distributed to the medical practices of physicians who score in the top performance. For this system to improve overall quality of medical care, which of the following is the most important to consider when determining about amounts of incentive distribution? Wait. Which of the following is the most important to consider when determining amounts of incentive distribution? Okay.
Okay. Pay for performance systems are intended to improve. Pay for performance systems are intended to improve healthcare outcomes. Healthcare outcomes by linking physician financial incentive to delivery of evidence-based care. Patients complete recommended colon cancer screening. However, for such system to improve overall quality of care, they must address equity delivery of high quality care regardless of demographic attributes. Who, okay, evidence suggests that the practice serving affluent population are more likely to achieve pay for performance quality metrics. Patients have more resource to afford recommended medication or follow-up tests. As a result, these large neonatal pay for performance network, which may preferentially reward for reward more physician in affluent regions, increasing gaps in resources and health outcomes before poor and high income is reading. Okay, therefore, pay for performance systems are recommended to consider demographic characteristics of the patient, insurance type, income level, and surrounding the community status, such status as health professional shortage area, where determining amounts of incentive payments, higher payments for quality achievement to practice located in health professional shortage area.
Okay.
It
Can
is
you?
like what is it like? We are paying instantly for his performance, like his what is
Uh,
paid for performance.
it's like, oh my God, my tutor just taught me that today. It's like you give it can be, I guess, money usually.
Yes,
Like you
money.
can say, oh, yeah, usually money, because your patients are following your. You know what? Let me just read what he just he just told me,
Okay.
because we just did that yesterday. Pay for performance incentive payments to the provider based on clinical performance, clinical improvement of the patient. So the patient gets better quick, and you get money for it. You have a bunch of patients and they get cured quicker, they get better quicker, then you get money for it. Then now my tutor say it's not good, because if doctor, let's say I'm a doctor and I see mostly like rich patients, and you are a doctor and you see mostly like poor patients, so your patients are going to take longer to get better, maybe because they don't have health insurance or because they cannot afford the medications because they're poor. But my patients are going to get better quicker, because they have all the money to buy all the best medication, and they have all, all these things. So this they say that this is the problem with pay for performance. Do you get what I'm saying? Does it make sense?
Isn't it improving, like if you give paying for the performance, then his working wish will be enhanced, like he become more enthusiastic for
Yeah,
working.
definitely, the doctor becomes more enthusiastic to cure the patient. So that part is good. That's the good part. But now you're not looking at the part of the patient. Now, if it's your poor patients, even if you're working harder, you're telling me you need to take this medication every day at 2 p.m., whatever. Yeah, you're doing good, but the patient cannot afford the medication. The patient cannot, you telling him you need to go to your rehab appointment every day so you can get better. But the patient don't have money for transportation to go to the rehab appointment. So he's not going to get better, even if you're doing everything right. Your side is good, you're doing everything right because you want your money. But the patient cannot, he doesn't have the means to do all that you're asking him to do. But my patients that are rich, I tell them the same thing. You need to take that medication every day. You need to go to rehab, whatever. And they have the money. They can even call the rehab people to come to their house and do the rehab at home. They have, you know. So if you're looking from the doctor point, yes, it's good. The doctor is going to do more to get the money, to get the incentive. But if you look from the patient point, then the rich patients, yes, are, can do all of that. The poor patients cannot do all of that. So they have to pay for all of that.
Stopping the risk of stopping her current medications can be addressed at a later point. Okay.
83-year-old man with type 2 diabetes, history of type 2 diabetes, hypertension, hyperlipidemia is preparing to be discharged following hospitalization for asymptomatic hypoglycemia. The patient is a retired college professor who is fully independent with all activities of daily living. He lives alone and receives weekly visits from the daughter who lives several miles away. His last A1C was 8.2. The patient is advised to stop taking his previously prescribed medication of combined metformin and glyburide, and is provided a new prescription for metformin only, brand name glucophage. Oh, the brand name of the metformin glyburide combination is glucovence, and the one for metformin only is glucophage. The prescriptions are updated in the electronic medical record, and the patient is scheduled for follow-up with PCP in 2 weeks. However, 6 days after discharge, the patient is brought by his daughter to the ED Due to mental status changes, finger stick glucose is low. The patient states that he is taking only one anti-diabetic medication and has not taken any additional doses. He has his med bottle with him. On reviewing the bottle, the physician notes that the patient is still taking the combined metformin glyburide pill. Which of the following practices is most recommended to reduce the likelihood of medication errors in similar patients?
Okay, ask patient to describe the changes made her. Okay. The patient experiences hypoglycemia after taking discontinued. The patient experiences hypoglycemia after taking a discontinued medication combined metformin glyburide instead of a newly prescribed medication metformin. Adverse drug events occur frequently, causing one-third of all hospitalization in adult advanced age. Age more than 75 risk increases. Sound alike medication, glucophage or glucovans, antidiabetic drug causing hypoglycemia, glyburide, and polypharmacy common in elderly patients who take average of 8 medication daily. Provider medication counseling increases provider medication counseling increases adherence and health literacy. Patients' capacity to interrupt and act on health information reduced adverse drug reaction. Counseling should be patient-centered and encouraging patient participation include the following: interactive methods such as tech interactive methods such as teach back, in which patients describe their understanding of a new treatment plan. Patient describe their understanding of a new treatment plan. Having these patient explain his understanding of his medication adjustment. After provider counseling, teach back efforts, opportunities to correct miscommunication and clarify areas of confusion sound alike drugs, vague instruction. Such interactive approaches are most likely to improve comprehension and adherence compared to relying on passive approaches, handout or discharge summary, or asking general questions whether patients have any concerns. Plain language discussion of new drug names, brand and generic indication, dose, frequency, take with breakfast and dinner rather than take every 12 hours. Okay,
Next.
okay.
So, oh, 29 woman comes to the ED due to acute lightheadedness. The patient was seen by her family physician for viral GI gastroenteritis 2 days earlier and was prescribed ondansetron. She has taken the medications twice daily since then, with significant reduction in vomiting. Medical and family history is fine. The patient takes no other medication. While in the ED, she develops VFib and becomes unconscious, requiring cardiopulmonary resuscitation and defibrillation. The patient regains consciousness with normal sinus rhythm and is transferred to the ICU where she has no further arrhythmias. After consultation with the cardiologist, it is believed that ondansetron may have triggered the patient arrhythmia, an adverse effect that occurs in average 2 out of 10,000 patients. Oh. Which of the following best describe the family physician medical liability related to this adverse event? It's 2 out of 10,000. Oh. Mm.
Okay. This patient is experienced a relatively rare 2 in 10,000 adverse drug event cardiac arrhythmia due to ondansetron, a medication commonly prescribed for nausea and vomiting. To determine whether malpractices occur, all the following: the physician has duty to care for the patient, and patient-physician relationship has been formally established. The physician's actions deviated from the standards of care typically determined by current guidelines, and the deviation from standards of care directly caused damage to the patient, which may include physical injury, emotional suffering, loss of wages. Damages need not to be reversible for malpractice to occur. The physician had a duty to care the patient, and the physician prescription ondansetron likely directly caused this patient's arrhythmia. However, this patient had no known risk factor for arrhythmia, and be reasonably detected that would be reasonably detected under current standard screening procedure. The patient has no personal or family history of cardiac arrhythmia or take other proarrhythmic drug, does not take other proarrhythmic drug like antipsychotics. Therefore, the physician's prescription adheres to standards of care and does not constitute malpractice. Okay.
Okay, next. 35 men comes to the office for a preventive exam. Medical history includes asthma. The patient has smoked for like 20 years. He tried quitting 3 years ago on his own, but was unsuccessful because he felt very jittery without cigarettes and restarted smoking to relieve the system. The patient is hesitant to attempt smoking cessation again because he does not want to relapse and be seen as a failure. Which of the following is the best response to the patient?
The patient is not ready to stop making sorry, the patient is not ready to stop smoking. However, his previous attempt indicate that he is aware of the benefits of the smoking cessations and he is likely motivated to quit. Behavioral therapy combined with pharmacotherapy is the most effective strategy for smoking cessation. Behavioral therapy should address the patient's motivations and barriers to quitting. These patients' main barrier is nicotine neutral syndrome, marked jitteriness, which are likely to benefit from pharmacotherapy and possibly behavioral therapy intervention. Supportive therapy is an effective approach for smoking cessation, and can easily be provided in a routine office visit. Supportive therapy provides encouragement to the patient and often includes the following: education about the process of quitting, quiet, selecting a quit day, and choice of pharmacotherapy. Reminder that the initial failure is common and patients may require several attempts before achieving long-term success, and reassurance that over half of the smokers can eventually achieve long-term abstinence. Okay.
Okay, next. 63 men comes to the ED an hour after sudden onset dysarthria and right-sided arm and leg weakness. Acute ischemic stroke is suspected. The patient is a candidate for administration of TPA and consents to receive the treatment. The patient is weighed, but the weight in pounds, 160, is erroneously entered in the electronic or medical record as 160 kilograms. The dose of TPA based on a weight of 160 kilograms is calculated, verified by two staff members, and dispensed by the pharmacy. As a result, the patient received excessive dose of the medication. Which of the following interventions will be most effective in preventing this error? Hmm.
Okay, can you tell me the dose-dependent hypertension done by one antidepressant?
Oh, no, I don't know that.
Sorry,
No, what do you mean that those? I don't understand.
like a patient is diagnosed as uh, major depressive disorder,
Mm-hmm.
and we give antidepressant therapy,
Mm-hmm.
and these antidepressant therapy is causing a new onset hypertension.
Mm-hmm.
Which of which drug can cause this? Like which of the antidepressant?
No, that's venlafaxine.
Okay, yes, that's venlafaxine. Okay, so dosing miscalculation,
Which
dosing
one is the which one is the antipsychotic that causes gray green rash on the body?
antipsychotic causing
Is a typical antipsychotic that causes gray green rash. No, I was lost to when I saw it on the, I was lost to when I saw it on the second. I was like, I've never seen this. It's the
typical antipsychotic.
typical antipsychotic. Typical. The first generation.
Is it flufenazine,
No, that's
thioridazine,
no. Um,
trifluperazine,
no. What's the other one? The C one,
chlorpromazine?
called promazine. And which one is the one that causes hypothermia?
The antipsychotic,
Yeah, first generation.
first generation antipsychotic causing
Hypothermia.
flufenazine.
Yeah, Yeah. I know. I just saw. I was studying yesterday, and I was like, I've never seen this before. Like what? But yeah. Okay.
Chlorpromazine, what is the adverse effect?
It says it causes a gray-green rash on the body.
Gray green rash. Okay, like there are some amiodarone has like this type of side effect.
Yeah, that one I know. That one is like everywhere. The weird gray thingy. Like I don't remember the. Yeah, that one I know. And then there is another one that causes another antibiotic that causes some kind of rash. I don't remember which one it is. But those ones are common.
Like you are talking about Redman syndrome, like vancomycin.
The vancomycin, and then there is another one on sketchy with the kid in the pool. I forgot that one. I forgot the name. But those ones are common. Like I feel like if I show you will know that one you probably know. But this one for the antipsychotic, I had never heard those before. The
Okay,
hypothermia thingy. Yeah. Okay.
okay, I'm reading the explanation. Okay, so dosing miscalculation for systemic intravenous anticoagulation, heparin, tissue plasminogen activator are a leading cause of fatal medication error. Task complexity is increased because anticoagulant may require different way-based dose calculation and often rely heavily on accurate measurement and recording of patient weight. Medication administration safety Medication administration safety can be improved through the system-based strategies that reduce human effort needed for correct action, such as standardization and simplification. For example, standardize equipment to display only metric units, kilograms, eliminates the effort needed to manually record the correct units of weight, and also representing simplification of process and has the greatest potential to prevent dosing error in these patients. Other interventions such as modified workflow policies uh, requiring pharmacists to review medication dose calculation and visual cues using prominent computer fonts that draw attention to high risk data in patients should enhance enhance safety. However, compared to standardization, these methods require more human effort and are vulnerable to operator error, distractions, workers fatigue. System standardization is more effective in prevention because it completely eliminates the error prone action, that is differentiating between pounds and kilograms manually entering unit. Okay.
43 woman comes to the office due to concerns about the health of her lungs. Her aunt who has a 25-year history, recently passed away at 62 from an aggressive lung cancer. The patient has no symptom but is concerned she may have lung cancer because she smoked a pack of cigarettes daily for 5 years because before quitting like 20 years ago. She said, my brother is a hospital administrator and he says that I should get a CT scan of my lung to make sure I don't have cancer. Can you order one for me? Which of the following statement best describe the principle of patient autonomy as it applies to this request? Which of the following best describe the principle of patient autonomy? Mm. Mm, B and C. The patient autonomy to receive any requested medical service. That makes sense. To receive the requested medical service applies in this case. Oh, no, it's C.
Okay. The principle of patient autonomy, the principle of patient autonomy mandates that competent patient have unrestricted rights to be informed about a treatment risk and benefits, select among medically acceptable alternatives, and refuse treatment if desired. However, autonomy does not obligate the physician to provide mm, non-indicated or inappropriate services regardless of patient's request. The patient's autonomy to receive a requested medical treatment is always subject to the physician's medical judgment and discretion. When deciding whether to provide a requested treatment, the physician should consider whether the treatment is consistent with ethical and evidence-based scientific standard, whether the treatment potentially benefits the individual patient beneficiaries, whether the treatment avoids unnecessary or excessive harm, non-maleficence. This patient requests a CT scan for lung cancer screening, but her light and remote cigarette use does not constitute a strong young risk to warrant screening based on the current guideline. Screening outside these guidelines is associated with increased morbidity, invasive biopsy procedure to evaluate incidental findings of because the risks of screening outweighs the potential benefits for the patient. The physician may ethically choose not to provide this treatment, even if to prevent unnecessary harm. Okay.
58 men with history of well-controlled hypertension comes to office due to low back pain for the past 5 days. He first noticed the pain when bending over to lift a package at home. The pain radiates into his right leg with mild weakness. He has no numbness or bowel incontinence. He has been taking acetaminophen and ibuprofen as needed for the pain. He was as an accountant at a large firm. Temperature is fine, BP fine, pulse fine. Exam, neurologic exam 5-5 strength in the left lower extremity and 4-5 strength in the right lower extremity. Reflexes are good everywhere. Straight legs raised test is positive in the right. The physician diagnoses with sciatica and recommends therapy and strengthening, physical therapy and strength exercise. The patient states that he is unable to sit for more than 2 hours without feeling the pain in his leg and that it is interfering with his job. He says, I just don't see how I can work right now. Can you help me qualify for Social Security disability? What is the most appropriate next step? Next action by the physician. weird question.
Okay. Disability insurance. Financial assistance for employee unable to perform full job studies due to illness may be short term, less than 6 weeks, or long term, offer through private insurance or Social Security Administration. Clinicians will document findings related to medical condition, define severity and expected duration of the condition, identify restriction and job-related function limitations. Challenges: disability definition and certification requirement vary by program. Determining disability duration may require longitudinal and repeated evaluation, and clinician assessment may conflict with the patient's preference. Disability reassurance, disability insurance provide employees with financial assistance if they experience a medical condition impairing their ability to work. Short-term disability less than 6 weeks is typically offered through private insurance programs, whereas long-term benefits may be funded privately through the Federal Social Security Administration. Disability benefits are often contingent upon upon physician certification of the patient's impairment, including severity, limitation of the job-related function, standing limitation, and expected duration, temporary, permanent. This patient has sciatica causing functional impairment and unable to sit for more than 2 hours. However, he has only had 5 days of symptoms. His duration of his impairment is uncertain. Mm, Moreover, it is possible that workplace modifications, changing computer positions, periodic break may enable to fulfill job obligations without extended time off. Therefore, it is inappropriate to certify the patient now for long-term disability benefit. Instead, the physician can certify the patient for limited time of 3 to 5 days for medical leave and subsequently reassess the patient.
You read D as in dog. Oh, sorry.
If somebody
Yes,
is
go ahead.
getting like long-term disability certificate, then they uh, need not to do anything. They are just sitting in the home and enjoying their life.
Mm-hmm. Mm-hmm.
Okay, that
You read D as in dog. That's what?
that's why he is requesting for that.
Mm-hmm.
Okay. Visit summaries uh, which contain detailed patient information belonging to the patient's medical record are not generally intended to be reviewed by the employees. When a patient requires extended medical leave through the Family Medical Leave Act, the physician's disclosure of pertinent health information with the patient consent is typically limited to information requested: date of the disability, where I am. When a patient requires extended medical leave through the Family Medical Leave Act, the physician disclosure of a pertinent health information with patient consent and is typically limited to information requested, that date of disability onset, nature of limitation on a standard employer generation form. Okay,
Okay. Okay, we are done. We take a break so I can open the other block.
yes.
Okay.
So you
I'm
are
done.
having your like
What?
breakfast.
Yeah, so I can have my breakfast.
Okay.
Okay, thank you.